I will connect you with some new resources here. I'm going to skip on to our next slide. And I know this is a lot of fine print, but we do want to announce, and we're pleased to show you that we do have our econsultworkgroup.com revamped website. It's exciting to have had a toolkit for you all, and with so many of your contributions over the past 2 years, it was time to really refresh this. And with so many of your contributions, we want to make sure that everyone takes a look at our new website, our econsultworkgroup.com, where you can find a recap of our annual meeting. So those of you who attended on November 16th, that's wonderful. If you didn't have a chance to attend, what we do have is recordings of our sessions. So you can take a look here. You can see some highlights from our meeting, including what we called our Fireside Chats, which was the way that we kicked off our meeting just to sort of liven it up a little bit. We had breakout sessions with Arista MD speaking to Econsult and pace settings, Conformed speaking to nutrition guidance through Econsult, Rubicon MD highlighting behavioral health use in Econsult, and SafetyNet Connect sharing lessons learned from VA. We also have a recording of our keynote speaker, Dr. Wando Olewola. She really did kick off our event well, focusing on our theme, which was access to care in a time of crisis, with her presentation around social justice and equity through Econsult and telehealth. So thank you, Dr. Olewola, for kicking us off in a meaningful way. Throughout our day, we have our additional featured presentations. We have our payer collaboration session from Anthem and HealthNet, and provider engagement examples from IHP and Wise Healthcare. So a good number of recordings if you'd like to access those and share those as relevant with your teams. Another feature that we wanted to share with you, oh, I forgot, my next slide is just a quick thank you. I mentioned a good number of our sponsors on that last slide, but we could not have had this meeting that we had with 200 folks on that call without support from our sponsors. So Anthem, Arista MD, Rubicon MD, Conformed, IHP, SafetyNet Connect, and Wise, thank you so much for your support over the last year. Of course, our overarching support from California Healthcare Foundation. We could not do this without CHCF. And we're looking to 2021 now. Thank you so much for those who supported us this year. We hope to have additional support to move our work forward in 2021. And thank you, IHP, who's committed to sponsor in 2021. One feature we wanted to highlight of our new website is a playbook. And this is a way that we've been able to feature a good number of our members' use cases and great practices and strategies for success. So please do take a look at our playbook, which highlights your great programs. I'm admitting some folks to our call. Hold on one second. We have a lot of people in our waiting room. So wanted to highlight some, not just California examples, but those from across the country and internationally. So we have examples from Connecticut, from UC Irvine, from down south at IHP and Wise Healthcare, but also examples from Ohio State University and our friends up in Ontario, Canada. So thank you so much for those who've contributed to our playbook, and we want to keep this fresh. So as you share great stories with us, we'll make sure that these are posted to our website. Thank you so much. And with that, I'm going to hand off to our featured speakers today for the day, Amber Nicolette and James Wheeler. So Amber and Jess, if you don't mind unmuting yourselves, I'll click for you if you don't mind, and you can just tell me when to advance the slides. As we do that, I'm going to make sure that everybody else is on mute so that nobody is distracting you. And Amber and Jess, if you don't mind just introducing yourselves, and I will hand off to you. Go ahead.
Sounds good. Well, I'm Jess Wheeler. I'm a nephrologist primarily, but also spent a lot of time doing quality improvement and divisional medical director duties, which led to my involvement with the Econsult process. I'll let Amber Larson introduce herself, and then we can get going here.
Yes. Hi, everyone. I'm Amber Larson, Jess's dyad partner in all the work that we're going to talk about today. And yeah, I think that my name got blended with our organization. So I'm Amber Larson. Our organization is Park Nicolette.
All right. Well, again,
I'm so sorry, Amber. That's embarrassing. How did I do that?
No worries, Libby. It's fine.
Well, again, thanks a lot for having us. You know, I have to say, this is exciting work looking at your organization and all the work that everybody's pulling together. I can tell you that this would have been very helpful as we would have had I known about this, had Amber and I known about this, rolling this out. So our story is we work at Health Partners Park Nicollet. It's a combined organization primarily based in Minneapolis and St. Paul, but it's got a large footprint. Like many of your organizations, we cover a lot of rural area. It also includes inner city, a lot of underserved populations, a lot of elder care. We cover a pretty big footprint going into western Minnesota, eastern Minnesota, and then western Wisconsin as well too. A lot of different hospitals, clinics, and because of that, as you all know from your organizations, the access to specialty care became a real burden for us, a real problem. And so not only the number of specialty physicians available to find time slots, but just getting people from point A to point B. Again, that's not anything new. And especially if you're listening to this, this is an issue that you've dealt with and continue to deal with. Quickly as background, our goal was for a long time to have any patient be seen in any specialty clinic within 14 days. And we just saw those numbers starting to rise. And that wasn't, no one was happy with that, and that wasn't okay. So I think it was 2016, 2017, we started to investigate this idea of e-consults, and it certainly was not an original idea. I think it came from just reading what other organizations were doing. It is likely there are people here on this conference call who had done a lot of work that we read, and so we really appreciate that. We did a large literature search, kind of a proof of concept investigation. We then brought that to our senior leaders, and we can tell you more as we go. Next slide, please. So our e-consult process is very much like most of them, certainly not like all of them. I know there's some differences in other organizations that we've spoken to. It sits right in the middle between the informal hallway curbside consult and the in-person formal consult. And as you all know, the curbside is great because it's fast, or you can send a page to a clinician and get an answer pretty quick. The problem is it's not documented, so no one really knows 6 months or 6 years down the road whether or not it happened or what was that plan. And the in-person consult, the classic consult, is problematic for all the reasons that we all know and that we cited. Certainly in Minnesota and Wisconsin, there's a lot of snow. It's really hard to get people from nursing homes, assisted livings, into the clinic, just for routine care, let alone if you want to try to get them into the clinic in a short amount of time. So eConsults sits right there in the middle. Next slide, please. So we investigated this idea. We did a lot of talking about it, and then we brought it to our executive leaders. And this is just a high-level view of the way we have things set up here. Medical specialties at the department level, surgical service line, local clinics, primary care. That also involves emergency departments and urgent care clinics. And then if you look at the top there, executive sponsorship, or our care group council is what we call it. Those are the senior leaders of managing the entire organization. And so we brought that to various levels of leadership. Everybody seemed to be very interested in the idea. Getting into the weeds was where the work began. Next slide, please. Real quick, before I get into this slide, I will mention one of our goals, and one of the things I think we did either by luck, but also with some planning, was to try to bring it to the leaders, and whether it's primary care leaders, urgent care, emergency departments, specialty leaders, and ask their opinion. And our goal was to try to have them poke holes in our idea to find out where we were wrong, where this was a bad idea. And that really helped move the process along. What's on this slide is how eConsult works in our organization. So this is fundamentally a conversation between one provider and the other provider, meaning using the primary care clinician as an example, the primary care clinician has a question and will ask the specialist. Asynchronous communication, as you know, our goal is to have that turnaround within about 48 hours. The specialty clinician does not contact or communicate with the patient directly. So as this slide shows, primary care clinician talks to the patient and says, you know, we've got an issue here we'd like to learn about. We have a couple options, one of which is Econsult. And if the patient agrees to that, then the primary care clinician sends that request to the specialty provider. And within 48 hours, the expectation is that the specialty provider will send a response. It is then up to the primary care clinician to act on that or not act on that. If it seems very inconsistent with their patient's goals, very inconsistent with what they know about the patient, then they certainly have the choice of not following through with that. Next slide, please. I'll turn it over to Amber now to talk about some of the results that we've had as of late.
Great, thanks, Jess. So it just alluded to the fact that we spoke with a lot of different leaders in different parts of our organization and many different medical and surgical specialties. We have about 55 across our enterprise. And we did make a fairly deliberate decision to, rather than pilot this in just a few areas, to do a big bang rollout with as many specialties as we possibly could. And the thought process there was really knowing that our referring providers needed to have critical mass in order to remember to do this process. We thought, well, let's get as many as we can going right away. And we knew that that would mean that we'd have variable uptake. There would be some specialties and some questions that would just be much better served by this process than others. And you can see on this chart some of our most frequently billed, most frequently asked departments are those like oncology, endocrinology, infectious disease. So none of that was a big surprise to us. Those happen to be medical specialties that Jess and I have responsibility for, endocrinology and infectious disease. So we knew that this was could potentially serve a role in those areas as they get a lot of curbside questions. So next slide, please. So something else we've been tracking and tells sort of an interesting story as we go into what happened during a pandemic using this functionality. We started using Econsult in June of last year, 2019, and that's a partial month of data, so that explains why it's a little lower. But we were seeing a pretty consistent run rate of around 200. Now I'm looking at this and I think the graph used to have a distinction between, now I'm interpreting my own graph. Line is those that were billed, the bar is those that were requested. So about half of those that are requested typically are billed. The others falling into those categories of just a simple, quick question that I can answer, or this is somebody who I really would prefer to see in person. So the specialist makes that call. But we weren't really sure what was going to happen with the advent of a lot of virtual care and with the pandemic. Our organization really didn't use a whole lot of video visit, phone visit. There was some here and there prior to April, but it really became a huge part of our practice, as I know it did for all of yours as well, starting in April. So we wondered whether having that would result in fewer e-consults or if e-consult was going to become just part of the virtual care toolbox for our organization. And as it turns out, we did see an uptick in use of e-consults through those summer months. So we were pleased to see that, and we anticipate that and all of the other virtual options we have available will persist for us. I'm seeing Libby's question as far as whether patients are commercially covered or covered by Medicare, Medicaid. We do have both in the mix here, and I'd have to get back to you on the specific breakdown of which is which. It's probably, if I had to guess, it's at least 60 to 70% commercial, but there is a significant chunk in here that is Medicare and Medicaid, and we are seeing coverage from those payers. It's not as good as the coverage that we see from commercial, but we do see some payment. So if you want to go to the next slide. So throughout the process, we've been deliberate about trying to get, as Jess mentioned, feedback from our clinicians and care teams, and basically what's working, what isn't working. And the good news is our clinicians have generally been very positive about this. So that people are really finding that it's getting quick answers to their questions, that it's been easy, that patients are really appreciating it as an option. So we've been pleasantly surprised. You want to go to the next slide, Libby? And this is just our last slide. As you all know, we recently submitted this case study and were published in New England Journal. And it's been really great to have the opportunity to tell the story. And I know all of you appreciate the benefits of Econsult in your own organizations. So we're happy to take any questions or anything further you might want to know.
Thank you so much, Amber Larson, not Amber Nicolette. And I'm embarrassed that I did that twice in our presentation. So thanks so much for your understanding. So Amber, my follow-up question to the line around commercial versus Medicaid versus Medicare. And since you're new to this group, we have a good number of those who serve Medicaid patients. So we have Medicaid managed care plans on this call, along with federally qualified health centers, public hospitals, of course, those who see commercial patients too. But this is very interesting that a majority of your patients for whom we see e-consults done in your program are commercially covered patients. Mm-hmm. How do you message that to, or I don't know if you've had conversations with those commercial plans? Maybe you can talk a little bit about how do you explain the value of e-consult to those plans?
Yeah, great question. And I think for us, the natural first step was Health Partners is an integrated insurer and care delivery system. So we started by just talking to our own commercial payer and trying to tell the story of why this was potentially a value both for us in care delivery and for them as a payer. So really acknowledging the fact that there were a lot of simple, straightforward questions that were getting a face-to-face referral in the prior world that could potentially be served by this less expensive option was something that was appealing to our internal payers. And we have several other commercial payers in the market who we have good relationships with, and they were very willing to come to the table and talk about it as well. So that was a couple of year process talking about what the value proposition might be. But Jess, what would you add to that?
As a clinician, I hadn't spent much time talking to, the payers, even in my general administrative role, but I was very surprised at their enthusiasm for those reasons. It comes down for somebody who's counting finances to be a really good, economic decision. As a physician, you'd think all about, is this the right care at the right time for the right person? And so I was pleasantly surprised at their willingness to think about this and think about a new alternative.
Thank you. And we have so many questions coming. I really appreciate this because this is a great and a new perspective for us all to hear. I had a fun conversation with Jess and Amber earlier this week when they said it was a great and a beautiful day. It was 20 degrees and sunny. So for those of us who are in warmer places in the US, my question for you is, does this have a great value in terms of rural patients, those who are dealing with travel challenges? Is that part of your messaging too?
Yeah, I would think
patient travel. Go ahead.
Yeah, I would think so. Definitely, the longer somebody has to travel, the more inconvenient it is. And also even for short distances. And as we all know, for a lot of people to get to their clinic visit, they need to have a family member take off work or rearrange their schedule in order to get that person there. Or if it's any other financed transportation, that can become really expensive. Taking an ambulance to a doctor visit is really expensive. And so definitely rural, our rural experience is an important part of this. The other thing, I did see a question about within or without the organization. This is by definition within our organization only. And so as much as we would like to extend this out farther and farther rurally, and it's a pretty big footprint, as I mentioned, it's still just in-house, basically. Anybody who's on our electronic medical record platform, anybody that's within our system, we don't have it set up for, the private primary care physician down the street or 500 miles away. So.
Yeah,
Thanks, that's
and
helpful.
part of the reason for that, I think I saw another question as far as incentive, or how do we work with both our specialists and referring providers? We do compensate both our specialists and the referring providers for the work involved in Econsult. So we do bill the 99451, the specialist does, but we made the internal decision to also comp the referring provider. And because we have employed physicians, it was felt that we could do that without it being a kickback or being perceived as something like that, because it's really an employment decision. But hopefully that addresses those couple of questions.
That is a great response, Amber. Super helpful, because we have that question a lot. Does this have the perception of referring, creating referrals? So that helps to clarify. I'm just going to go down the road. We're jumping around a bit, but really, really important questions here. Have you encountered any instances where a patient who had their issue results or requested by Econsult complained that they were not provided with an in-person or face-to-face visit?
I have not heard of any, and I'll speak to it, and then I'll let Amber answer, because she also talks to a lot of people that I don't talk to. A requirement of this process is the requesting provider has to have a discussion with the patient to say, are you okay with this? And if the patient has to be okay with the whole process, and that includes a discussion about the billing. And so I think that generally separates those that aren't expecting. So nobody who gets an Econsult, no patient who gets an Econsult, it should not be a surprise.
Dr. Wheeler, can I pipe in? I have a follow-on question there. I'm sorry to interrupt you, but since you are a nephrologist, do you have any language that you like to use for patients to explain how this is helping them?
Well, I'll answer that two ways. One, I don't talk to the patient who I'm doing the Econsult for. That language is left up to the primary care physician. And we can get into the weeds on sort of what I get as a request. I have requested Econsults, and when I have that conversation, it's just a real basic, straight ahead adult conversation of, we have several options. I'd really like to get the opinion of a specialist. And we have this new process called Econsult, which means that I can talk directly to the specialist. We can get that answer usually within 2 days. There are some benefits. It will save you a trip into that clinic. It will happen much faster than if you have to wait 2, 3, 4 weeks to go see that specialist. There is a charge that is associated with it. It's usually less or oftentimes a lot less than the in-person consult. And some people say, no, I want to go see that person in person. I will wait 3 weeks to see the neurologist or the pulmonologist. And some people say, oh, if I can find out sooner, I'm happy to pay the nominal cost.
Some people would say 3 weeks for a neurologist is amazing, right? Go ahead, Amber, sorry.
Yeah, no, that's fine. We did develop a resource too for our referring providers to give patients. It's just a kind of a third of a sheet of paper stick card. And it's an appendix in our article if that's something that you're interested in looking at. But yeah, it's basically just in patient language, exactly what Jess just said. Why is this something you might want to consider?
So helpful, thanks.
Mm-hmm.
Now,
if I can just
go ahead, Justin.
I was just going to add one quick thing that might be part of your other question as well too. Occasionally the requesting provider will get an answer. They'll communicate that with the patient, and that'll lead to several other questions. We generally feel that, an e-consult, for lack of a better term, buys you another question, another phone a friend. And so it's reasonable to receive an answer, you communicate with the patient, and then that generates a couple other questions to just send that question back. We talked about it. I did this, what you asked, and this is where we are. that's a reasonable, 1 or 2 questions. It does not mean you get to do that for the next 5 years.
Right.
And so I think having that option also gives the patient some comfort that they are involved in the whole process.
One other nuance related to billing the 99451 is you can't actually bill that and a face-to-face visit in the same specialty within 14 days. So we do have a claim edit set up that if, for instance, a patient were to have an e-consult and then they did need a face-to-face visit within the next 2 weeks in that specialty, we write off the e-consult.
Amber, this is actually a perfect segue into this next question here, where looking at your report, are some of those consults that weren't billed those that ended up as face-to-face, or is that not how it works?
Yeah.
Okay.
So the ones that are not billed, we don't have a good way of distinguishing between the two other than chart review. So unfortunately, all that I have is a little bit anecdotal, but about half of what I've done chart review on of those that weren't billed are resulted in a face-to-face visit. The other half are, this was a quick and easy question, I'll just answer it and I'm not going to drop a charge.
Got it. Does Park Nicollet get, do you serve uninsured patients, or do you see a lot of uninsured?
Yes. As to whether we are doing e-consult in the uninsured population, I'm not sure. I think we could do some digging into that. Jess, I don't know if you have any recollection of seeing anything on that.
Yeah, I'm not sure of the data on that. It'd be interesting to look at. Again, with my clinician hat on, it's take care of somebody first and then worry about that. But I don't think that makes my bosses quite as happy. But
yeah, well, what is great about your program is that it's, it seems sort of payer agnostic, that everybody does have access to e-consult. So that's wonderful to hear.
Right.
Getting a little bit detailed here, do you, and Dr. Wheeler, you mentioned that, the primary care provider is responsible for communicating this to the patient. This question is there a way you can ensure or check that the treatment plan was delivered back to the patient? I guess in the EMR.
Yeah, so I also saw a question. So our EMR is Epic. And we do a lot of communicating between providers within that, even pre-e-consult, post-e-consult. This actually came up for me a week or 2 ago. And actually, that's not the case. I saw somebody in person for a follow-up consult to an e-consult. The plan had been implemented by the requesting provider. The patient just didn't want to do that. Mm-hmm. And ultimately, then it led to an in-person consult. I realize that's a convoluted story, but the bottom line is all three people, all three legs of the stool, if you will, the patient, the requesting provider, and the specialty provider can opt out at any point. So if a request is made, the specialty provider says, this is way too complicated for an e-consult, they can turn that immediately into an in-person. Or if it's so easy, as Amber said, they can just send a note. If the primary care provider just doesn't feel that it was an adequate answer for whatever reason, or it just didn't meet the standard of what they need, they can change that. If the patient, as in my recent instance, didn't feel like they were comfortable with the direction or what needed to happen, they can then say, I really need to see the person in person. So I don't know if that answers your question, but there's always an opt-out.
Very helpful. And I'm looking at your overview. I wanted to point out that we shared the link to this article in the email we sent out today. So if you want to read the full article, you can click on that link. But Dr. Wheeler, Amber, this says you've been going for less than a year, or is it about a year now?
A little over a year. So we started in June of 2019, and we've had a couple of phases. We went live with the vast majority of e-consults last June. But we've added in another 10 or so in 2020.
Great. And what's the volume you've seen today? How many have gone through the process?
I should have pulled that before this call. It's been over 3,000 that have been requested. And it's probably even more than that, because the last I looked at it was a couple months ago.
Wonderful. This is a really common question we hear about how do you get on your specialist schedules to be able to do this? How do you, of course, the incentive or the compensation is helpful to get them engaged in this, but do you block time? Do you put time on their schedules to respond to eConsults? They just do it in their time, in their between visits?
Yeah, what we decided to do, we thought about blocking time, and even as we were working through the payment model, we thought maybe it's such an important total cost of care, good care model that maybe we just block somebody's time every day. And we decided not to do that. And ultimately, we just decided to let each department handle it the way that they wanted to handle it based on their workflow. Because as you all know, the workflow for a urology department is likely very different than the rheumatology department. When people have time, what questions they're going to ask, how long certain things would take. And so in nephrology, for instance, we just have set up that every weekday, one of our nephrologists is the Econsult person of the day. And all of those requests go through the electronic record, Epic, and one of our nurses just checks, and she knows that if it's Dr. Wheeler, she's going to send it over and put it into my inbox. And if there aren't any, then there won't be in my inbox. And so that's how we decided to handle it in our department. Other departments have decided to do it a different way. Some people might be on for an entire week, but it's just up to the departments.
I think that was key for us culturally, to give our specialty departments a little bit of ownership and flexibility in how they wanted to do this. And, I don't think we ever said you can't hold time, but what we said is we don't expect that this is going to be a huge portion of your day. And in fact, that's proven to be true. Even in our very high volume specialties, we see, maybe 5 to 6 a week. It's not enough that it would really justify blocking time.
That makes sense. And I just want to point out, Dr. Wheeler, that Dr. Tuo, who just sent the question around designating a specific specialty e-consultant, I think you answered that question, but you're both nephrologists, so I wanted to point that out. It sounds like you have a sort of a specialist of the day, right? Someone who's assigned for that day.
And I might add the best specialty, but that might be my bias.
Right, of course. All right, so we have a lot more questions coming in, and I want to be respectful of your time here. So this is a good one. Do you know of other systems in your market who are following your lead and adopting eConsults? And if so, are commercial payers in your market playing a role in helping to spread?
It's a great question, and I'm actually not familiar with whether we've got probably 4 major care delivery players in our market, and I don't know that any others are doing anything quite like this. Jess, do you know?
No, I'm not aware of anybody else.
So thanks so much. And I want to wrap up and ask you to sort of share some final comments here, and maybe you can just reflect on what recommendations you'd make as systems like yours try to implement eConsult. What would your recommendations be?
Ask a lot of questions, get a lot of feedback, poke holes in it, like Jess said, try and figure out where it's going to go wrong or where culturally your organization might need it to go in order for it to work. This took far longer than I think either one of us expected it to. But ultimately, I think it ended up working out right for our organization.
Yeah, I'd agree 100%. And, even though we thought it was a really good idea, again, reading a lot of the literature of a lot of people who are from organizations that wrote a lot of that, we thought it was a great idea, but not everybody thought it was a really good idea. In fact, some people thought it was a really bad idea. And so then we would have to go have meetings with different service lines, and then we'd have to go back 6 months later and say we made some tweaks and adjustments to it. And eventually, not everybody likes it. That's not true at all. But I think a lot of the people that were really skeptical had some input. And as we say, it's a lot harder to not like something if you were involved in developing it. And then I will just say, thanks for having us. This resource for anybody who's meaning your organization, anybody who's interested in looking at it, looks like it's just a tremendous resource for all of this. We're flying blind a little bit, but I'm looking forward to following what you guys are doing.
Thank you both. And we hope that we can have you as part of our conversations next year and ongoing. It's been really great to talk with you today. There's one last question around specific billing codes that I'll take with both of you offline, since I think it might be more detailed than we can address briefly. So Sean will make sure that we get that answer to you offline. So Amber Larson, Dr. Wheeler, thank you so much. And please feel free to stay on, and we'll talk a little bit about what we've learned over the past couple of years and our direction for 2021. So thank you both.
Sounds good. Thank you.
So a lot of these themes that we tried to probe a little bit into are things that were touched upon by Amber and Dr. Wheeler. Just trying to figure out what's happening across the country with regard to payer support for Econsult programs. We were so pleased to hear from the Minnesota program that there is commercial engagement in supporting Econsult. We've seen a great amount of uptake from Medicaid and state Medicaid programs across the country, and it's great to see that this has spread across business lines. So what we wanted to know is what's happening, what in terms of payer support, not just in California, but how is Econsult being captured in terms of CPT codes? What incentives are being handed out or conveyed to providers to get them engaged? What communications are taking place between payers and providers, and how can we help with that? What can we do as an Econsult work group? And how do we engage primary care providers and specialists when they want to join programs? So we have people reach out to us wanting to know if they're happening, just as we just heard from our team in Minnesota. What else is happening in the region? So we want to be able to learn more about what's happening. So just very briefly, wanted to share our small group of respondents. We didn't have a huge number of responses, but hearing from 7 payers, we see that 99451 is the most frequently reported code. We see other 99452, which is the primary care provider CPT code used, and then where you see in Medicare 99446 through 99449. So clearly, and as Amber just shared, 99451 is fairly common. We, in 2021, want to move forward and encourage that reporting and capturing of Econsult using CPT codes. So just wanted to see what's happening and where we can support moving forward. Asking about provider incentives. So what are payers doing to support provider engagement in Econsult? At this point in time, the resounding response was, right now, there aren't incentives in place, and we know that. We're very much aware that there might be reimbursement taking place, but payers are just starting to get those incentive programs in place, and we want to share best practices and examples of where this is happening. And in our next couple slides, we'll be talking about that. So what we're seeing happening across a few programs is that the Econsult platform is paid for by the plan, or there are incentives or grant programs offered to the providers to get them engaged. So one of the narrative responses was that platform costs are paid for and specialists may be reimbursed directly, as is happening in the Minnesota program. And lastly, I think this is really indicative of where we can spend some time and focus in 2021 is asking plans. Do you communicate Econsult as a priority in your materials or manuals that are delivered to providers? And so the big answer was no. So those plans that are supporting Econsult programs, we hope that we can help provide those tools to better communicate to providers that this is a tool to increase access to care and improve access. So if we can be that resource for materials in terms of education and communications, we would be happy to do that. So interesting findings, and they helped us to shape our priorities for 2021. And with that, I'm going to highlight one program that we've seen grow over the past few months. We're excited to share a bit about, and I believe we have Joel Gray on our phone call today. If we have you, Joel, I'll ask you to speak in a moment here. So if you want to unmute yourself as I talk a bit about the program. We were excited to see Anthem Blue Cross spearhead a program in the Fresno area, which, if you're not in California, is the Central Valley of California, where we have a lot of patients who are living in rural settings and may be faced with travel challenges and access to care, definitely a lack of specialists to be able to treat patients in the Central Valley. So what we were pleased to see happen is, with Anthem's kicking off the effort, we've had HealthNet come to the table and CalViva to work together to figure out how to extend Econsult to the FQHCs across Fresno and the surrounding counties. So it's exciting to see this program grow. We have 6 FQHCs engaged to begin using Econsult in January and February this year. And Joel, I think that you're on. If you want to say a couple words, would you mind unmuting yourself? Go ahead, Joel.
Yeah, I'm not dialed in, so can you hear me okay?
I can, yes.
Okay, great. Yeah, no, I appreciate you teeing this up, and you basically summed it up better than I would have. So I think you covered the details, but yeah, we're really excited about this. I think in some ways it's a first of its kind, trying to bring in kind of a less integrated healthcare system in such a large geographic area. Not to say that this hasn't been done before. I mean, we've seen coalition type models in LA, and we've seen them in the Inland Empire. But in this case, we're talking about two different health plans that serve the state for the Medi-Cal beneficiaries coming together to partner with then all the other FQHCs, safety net health centers, providers, the vendors that do e-consults and so on. So it's a little different since it really does require a higher level of cooperation, since we all have different levels of market share. It's not like one's just like, so large that they can just do this. So I'm really excited. Everyone's really come together and seems to see the value in this. And I do think it's going to have a big impact into people's lives as we go into 2021 and all these health centers actually start setting up the program. So just big shout out to BluePath and Libby and Timmy just for actually getting us all together and just making an effective partnership. Really appreciate it.
I muted myself. So I'm going to pass over to Jeffrey Nikonsa from Calviva. Jeffrey, if you'd like to say a few words, please unmute yourself. And Jeffrey, as you're getting unmuted, I just wanted to point out that this is featured on our econsultworkgroup.com revised, revamped, refreshed website. So please take a click and check out what's going on with the Fresno program. And Jeffrey, would you like to say a couple words?
Sure. Yeah. So thanks, Libby. And I echo what Joe said. And I think that overall, this program has been very good that we've been able to get it started in the Fresno County. We were glad to come to the table and support the providers in the community to try and eliminate any barriers that could be out there to try and get this program up and running. And from what we've been able to accomplish from the very few meetings that we've had within the work group, I think there's been a fair amount of collaboration, participation, and attendance at these work groups. So we're very encouraged to see the efforts and the activity that takes place from 2021 and onward. I think it's going to be very beneficial for the service area and the patients and the community.
Thank you so much, Jeffrey. We really appreciate this, and also appreciate HealthNet's willing to support this effort. So thank you all. We look forward to sharing and hearing your results of your program in the next couple of months. It's exciting to see it launch. With that, we want to talk a little bit about 2021. You've heard about this if you were on our annual meeting back on November 16th, you heard about our goals for 2021. And we just want to quickly recap these and hear a little bit about where we might focus and really spend our energy asking for advice from our clinical advisors. So we want to just really highlight three key themes here. So supporting eConsult adoption and sustained utilization. I think the examples we heard today are great. We want to be able to support the measurement, access, and reporting of eConsult. So being able to measure and report consistently those programs that we're seeing happening. And last, expanding reimbursement across plans and business lines. So seeing that plan collaboration, like part of our Fresno program, is so great. And also just seeing more examples of commercial programs. So thank you, Amber and Jess, for sharing that today. And with that, I'm going to hand off to our clinical advisors to say a few words. And I'll start with you, Dr. Tuo. Delphine, would you mind quickly introducing yourself, since we have a good number of new folks on the phone today, and just sharing your thoughts for 2021?
Yeah, thanks, Libby. I think, as you mentioned earlier, I'm a nephrologist. Totally agree. It is the best specialty. Based in San Francisco, and the director of our eConsult program at the San Francisco General Hospital, which is our tertiary hospital for our public institution or public delivery system in San Francisco. As many of you know, I've been involved in eConsult for about a decade now, and it really has been transformative for our system. And I think really for 2021, our goal is to continue expansion, as mentioned, and to continue support of eConsult, perhaps in less less integrated systems, which is why the Fresno experience or initiative is really exciting, I think, as a case study and as a way that we can really delve into lessons learned for further expansion, further engagement. It really is a win-win for all participants, referring providers, specialists, patients, and plans. And it's really trying to find the levers to make it high value for those individuals. And so really working on engagement, I think, will be our ongoing priority for 2021. And I'm excited for that.
Thanks, Delphine, and thanks for always being a great source of advice for us all. I think I'll take a moment. Greg Buchert, I think you're on today. Greg, would you mind quickly introducing yourself and sharing some thoughts?
Sure, I'm Dr. Greg Buchert. I am not a nephrologist, maybe the only nephrologist not on the call. My background is in pediatric emergency medicine, and I've been in C-suite roles with health plans for about the last 25 years. A couple things as far as the priorities we're moving forward. We're seeing a lot of, obviously seeing a lot of growth. We're seeing a lot of one-offs state by state in Medicaid. And I think, as was pointed out in one of the questions today by San Francisco Health Plan, that you start comparing face-to-face visits versus Econsult rates between Medicaid and Medicare. I think it'll be important to get better visibility really across the country as far as what rates are being paid to see, and also do they influence adoption. So I think that'll be important. As we're looking at the webinar series on provider support, I think it'll be important that we focus on both PCP support as well as specialty support. And also supporting the adoption is, how do those that are strong advocates approach their regulators, approach their state Medicaid plans, approach their insurance companies, and give tips and tricks for what's worked as those apostles of Econsult go forth and preach preach what the value of Econsults. I think that'll be important. And then also, I think it'll be important to help everybody speak in the language of those payers or those regulators. And so as we're looking at things like access and availability standards, how do we measure that? And also looking at a template for, as we talk about the measuring access and reporting Econsult, should there be a standardized template for everyone to use that we always is getting close to comparing apples and apples as possible? And so I think the consistency of those reporting activities will be extremely important.
Thank you so much, Dr. Buchert. And it's great to have that payer perspective. Your years of experience in leading payer initiatives is really valuable to us. So having Dr. Tuo from the large health system perspective, having supported Prime, and having Dr. Buchert is so valuable. We do want to note that Paul Gibney, who is a wonderful and helpful advisor to us all, is treating patients today. He is heading up the LADHS COVID response effort. So thinking of our providers who are helping patients right now. And with that, we want to redirect back to what was one of our priorities for our annual meeting this year, was really focusing on equity. One thing that we want to point out is that we do need to continue to think about the patient perspective. And I think that was a big part of our discussion back with Amber and Dr. Wheeler, is how do we communicate this to patients? We wanted to share a quick resource with you all from CPEN out in California, their telehealth fact sheet, which reminded us that we need to be thinking about consumer satisfaction with telehealth. So how do we better explain this to patients, especially patients who may not have access to technology? So that will be part of our theme, our focus moving forward in 2021, and something we will continue thinking about. I also want to give a tip of the hat to our Ontario friends. I don't know if we have Dr. Liddy on the phone today, but they are a machine of research. Every month we're finding great lessons learned from the Ontario Econsult program. So these are pieces that are featured in our monthly Econsult news. You all get that in your inbox. So just want to continue sharing those findings with you all, and you can find these all on econsultworkgroup.com too. We have some questions coming through, and questions and responses. If you're online, please do take a look. Amber, thanks for responding to some of these detailed questions in the chat. With that, I want to hand off to Robbie Franceschini. Robbie, I think you have a quick announcement for us all. Go ahead.
Yes, hello everyone, and good afternoon. We'd love to welcome you and your participation at the California Telehealth Policy Coalition's next monthly meeting, which will be this Friday, the 18th, from 1 to 2 p.m. And we're really excited to kick off this meeting as we enter the new year with a couple new committee chairs and some recent legislation that's already been introduced in this new legislative session here in California. And we'll also be kicking off the meeting with a couple guest speakers who are researchers down at Rady's Children's Hospital and UC San Diego Health, who will be speaking to access issues around telemedicine for pediatric populations, and specifically how telehealth can help with reducing no-shows. So we'd love to welcome you at our meeting, and please let us know if you'd like to be added to the distribution list.
Thanks, Robbie. I think you all have my email, so if you'd like to follow up and get involved in the Policy Coalition, please do let us know. We want to try to continue around our mid-month timeframe for our monthly webinars. We try to be a bit flexible, although we tend to meet 12 to 1 to allow providers to be able to join us. I know that's 12 to 1 Pacific, not always the best for our East Coast friends, but thanks for joining us when you can. And this group is open to your delegates. If you'd like to share this with your team members, if you're unable to join, you're welcome to do so. Also, we want to point out that recordings of these sessions are on our website, so you can visit econsultwork.com. If you're unable to attend a session, you can always find a recording of our presentation. So thanks again, Amber Larson and Dr. Wheeler, for your time today. We really appreciate it. We are thinking of you all during the holidays. I know this is a really tough and different holiday season, so thinking you all keep safe, and we look forward to talking to you again in January. Thanks so much.